Hey guys, welcome again to Endo Coffee. This is their third edition, and this time is just a mini series. I hope all of you guys are doing safe. 2020 has been a long year for all of us. So, today's topic I'm really excited about because I'm going to be talking about a new file system which Endostar has launched. I'm sure this system is going to help most of y'all get a little bit better at glide path management. So, let's get started with it. Okay, like I mentioned, my today's assignment is to talk about glide path management. Now, when you see this work, you can see a lot of anatomy. This can be achieved when you have a good glide path, which is subsequently expanded into wider shapes. This facilitates our arrogance to do their jobs and give us satisfactory results. Now, the importance of glide path has always been underrated when we talk about shaping the root canals. When we see a well obturated curved canal, we often are inclined towards knowing which system did this clinician use to achieve these shapes. Often, little importance is given in understanding how this individual has achieved this glide path. To throw some more light on what I just said, let me quote Dr. John West from his famous article, Endodontic Glide Path Secret to Rotary Safety. In this article, he says the amazing fact is that the subject of glide path has no formal training in the endodontic curricula of most dental schools. In fact, a PubMed central search of glide path and endodontics reveals 300 references. However, none of them actually describe how to prepare this glide path. Most of the references just say something like, of course, you must first make the glide path. Now, what exactly is the glide path? In aviation, the glide path refers to the course followed by an aircraft when descending for a landing. The purpose of the glide path is to establish a corridor so that the aircraft reaches the proper location at the end of the runway. Coming to endodontics, the glide path ensures that all the subsequent shaping instruments move unimpeded to the apex. What happens when the plane goes off the glide path? I don't really want to talk about this, but we all know what happens. Talking about what happens in endodontics when we don't have a proper glide path. This can lead to transportation, ledge formation, or even blockage of the canal with the debris. Coming back to Dr. John West's work on glide path, he describes the endodontic glide path as a smooth radicular tunnel from the canal orifice to the physiological terminus. Its minimal size should be a super loose number 10 endodontic file. The glide path must be discovered if not already present in the endodontic anatomy or prepared if it's not present. This path can be short or long, narrow or wide, or essentially straight or curved, depending on the anatomy of the tooth being treated. Now let's directly talk about guidelines on how to produce consistent glide paths. First and foremost, once you establish your access, locate the canal orifices. This can be done with your DG16 probe. Once you have access to these canal orifices, widen these orifices with any orifice opener of your choice. Next, follow the canals to its radiographic terminus. Properly assessing the preoperative radiograph helps in this step. We are trying to achieve the glide path till the radiographic apex to achieve the patency first. The patency can be achieved using your 10K or the 8K. In curved canals, I would prefer starting off with the 8K hand file. Once patency is achieved, you can now record your working length. Now this point, creating initial glide path. We should always remember that glide path is always present. It's up to us to follow, expand, and secure it. Calcifications always start from the pulp chamber and proceed gradually into the canals towards the apex. It is very rare that there is a stop in the apical third of the canal. In such a situation, more often than not, it is something that the clinician has done or rather missed that has caused a file to stop from proceeding towards the apex. A number of reasons can stop you from achieving your working length or even reaching the apical terminus. These may include the following reasons. The files are not pre-curved according to the anatomy, or there are sharp curves in the anatomy, or the canal is blocked with the debris created, or the file you are using is too big to shape the canal. Now let me show you how to verify or secure an initial established glide path. I have a video for this. Have a look. Here the file is already at the apex and I have recorded my working length. And I want to confirm my glide path now. So what I do is retrieve the 10K file at 1 mm increments and slide it back to the working length without any reciprocation. I'm just going in and out. If the file slides smoothly in and out of the canal, voila, we have our initial glide path. Let's get back to the presentation. Once the initial glide path is established and secured, we can subsequently expand the canals and carry on with our treatment. I always spend more time on creating a reproducible glide path as it helps me save time later while shaping with larger files. The last but most important point under the guidelines of obtaining a smooth glide path is expanding the initial glide path. Here you can see if you follow these guidelines properly, you can achieve good shapes and get satisfactory results. Coming back to talking about expanding the initial glide path. How do we decide whether the canal is ready for us to introduce our rotary files? Most clinicians jump into rotaries when they feel the 10K hand file is super loose in the canal. Most rotary systems today have their first shaping file sized at 15 or 17 or even 18 at the tip. Now that's a huge jump from the ISO size 10K of a K file. Whenever we jump sizes like this, the risk of errors like ledges, transportation, and zipping also increases. Now, some clinicians, after using the 10K file, like to use the 15K file before starting rotary systems. In my opinion, the 15K hand file is the most dangerous tool that we can use while doing endodontic treatment. The 15K file is a 50% jump in the ISO size from 10K. Plus, the 15K stainless steel file is a stiff instrument. The chances of a clinician creating a ledge is very, very high when we use the 15K file. So what can be done to expand the initial glide path? Yes, there are unique sizes like 12K available. These files are always helpful, but we need to realize that in the clinical scenario, if we are using the 10K hand file as our patency file, we have already gone 1 mm beyond the apex, and that has already made the apical size to ISO size 12. Mechanical glide path files have been there around for a while now. Endostar has recently introduced the Easy Path EP file. This file, sized at ISO 14 at the tip, can easily replace the 15K file for good. The tip being ISO 14 makes the jump from 10K not so big. Moving on to our next slide. Now, the debate of manual versus mechanical glide pipe file has always been there for a while. Let's look into some scientific data for this comparison. Now, this is a study which shows us that rotary NITA instruments are suitable for adequate glide path preparation because they promote less deviation from the original canal anatomy when compared with hand operated instruments. There are plenty of such papers which state that using mechanical glide path files causes less aberrations while shaping the apical third compared to manual glide path files. Also, we need to realize that when we use mechanical glide path files, the debris comes out coronally out of the orifice. Thus, post-operative pain while using mechanical glide path files is less compared to hand files. So now why rotary glide path files? I would say mechanical glide path files don't need to necessarily replace hand files. The 10K file is absolutely essential to achieve patency, working length, and your initial glide path. Mechanical glide path files can follow the initial glide path created using hand files. Now, these mechanical files are highly flexible due to the small size. They widen the initial glide path marginally. They provide better shapes for bigger sized rotary files. They decrease the stress on the consequent rotary files, thus increasing their life. Moving on to the subject of the day, what are these easy path files? Let's have a look. So the Endostar Easy Path files have a lot of features. They're extremely flexible, they are highly resistant to fatigue, they pass easily down the canal, and they are safe and fast to establish glide path. Talking about the geometry of this system, the initial 3 mm is 4% taper, followed by the taper is a variable taper, so it decreases and becomes almost a 2, maybe 2.2% taper. The tip size is 14, like I mentioned earlier. Exactly what I was saying, 4% variable taper with ISO size 14. Now, this is an important feature. Designing a glide path mechanical file is not easy. This file needs to be thin and at the same time have sufficient strength to bear the stresses, and it's the first file which we are introducing to expand the canal. Endostar has addressed this issue in two ways. Firstly, they've kept a huge core size, providing adequate strength to the file to withstand the forces while at work. You need to understand this is a very thin instrument. So the modified core size helps in its strength. Secondly, Endostar has gone a step further and developed an entirely new heat treatment technology for this file. Files used for creating glide paths are a technological challenge, like I said. They are the first to penetrate narrow, curved, and often calcified canals. They need to be thin and flexible, but also resistant to breaking inside the canal. This is why they thought of the amber HT technology. Now, this is an important slide. We all know that these guys came out with the Azure HT technology just a year back. Then why develop a new heat technology? The answer is simple. Now, in the Azure HT technology, there is no R phase. When the file is introduced inside the canal, it converts into its austenitic phase since the AF is at body temperature. Now, when the Azure file is rotating inside the canal, there is a stress-induced martensitic phase, which this file is known for, which helps to maintain its flexibility. Now, talking about the Amber HT technology, in the Amber HT technology, Endostar has tweaked the metallurgy a bit. They have introduced a very narrow R phase interval. So, what this does is when the file is rotating, since it's a thin file, the stresses acting on the file are more compared to the bigger sized and bigger tapered Azure files. So, this file needs some additional strength to withstand these stresses. The R phase is slightly stronger than the martensitic phase. So in these files, when the file is subjected to stress, it first undergoes a stress induced R phase transformation followed by a stress induced martensitic transformation, thus increasing the strength of the file at the same time maintaining its flexibility. Now, these are some studies done by the company where they found that the flexibility of this file increases tremendously when it's heat treated. We can see it's almost 167% compared to the 100% of the file without heat treatment. Similarly, the resistance to fracture is also better when it's heat treated with the Amber HT technology. This is the usual cyclic fatigue test, which all the heat treated files do. And here also you can see that after the file is heat treated, the cycles taken for file fracture are tremendously increased. This is to summarize all the features of the new EP files by Endostar. It's got a safe tip, it's got a modify S cross section, which we spoke about, the Amber technology, the decreasing taper, and the massive core. This is extremely important while using these files, the torque setting. We need to use these files at a low torque. A torque of 1 NCM is more than enough to produce the desired result using these files. The recommended speed of rotation is around 300 RPM. Yes, this file can also be used in the reciprocating mode, provided the clockwise motion is more compared to the counterclockwise motion. It can also be used in the OTR mode, again, provided the clockwise is more than the counterclockwise. I would like you all to have a look at this case. In the preoperative X-ray, you can see that the canal is fairly straight. But when I explored it using my hand files, I found a small apical hook. After using the 10K file, I jumped on to the EP files for this case. You can see how well it's maintained the apical hook here. I don't think using a 15K file would have helped me preserve this apical anatomy. Following the EP file, I moved on to Azure 2004. You can see even that follows the gentle apical hook. And then I managed to finish this case. I hope this tooth lasts for a long time in the patient's mouth. Okay, I have a short video to demonstrate how to use these files. Let's move on to that. So this is done on an extracted tooth. You can see the mesial roots are fairly curved in this case. So once the access was done, I tried to locate the canal orifices. Like I said earlier, the first thing I do is try and widen these orifices so that I can introduce my consequent files easily. Here, I've used the Azure orifice opener. Irrigate well after using your opener because you don't want any of the debris to block your canals while establishing the glide path. Whenever there's a curved canal, I often start with the 8K instead of the 10K to establish patency. So here I'm introducing a pre-curved 8K file in one of the mesial roots, going down gently in a watch winding motion. Once I get the tactile sense that I've almost reached the apex, I'll withdraw the file. Following the 8K, I move on to the 10K, like I initially explained. Remember, whenever there's a curved canal, always remember to pre-curve your hand files. I apologize for the slight lag in the video. So here we have a 10K file again. Okay, so I feel there's some lag in the video on my end. So basically, once you introduce the 10K file, you need to check the glide path, like I explained earlier, by moving it in and out in a smooth way. If the file slips in easily and comes off easily, your glide path is secured. Following this, you can introduce the EP files. Now you need to remember with the EP files, you don't need to apply any sort of pressure apically. The file will glide itself till the apex. You need to go in slowly, a good easy 3 to 4 or 5 strokes, that's it. Withdraw the file, clean the flutes, irrigate, reintroduce the file. In this video, I've gone slightly over the apex for you guys to make you guys appreciate that how easily the EP file has gone through the curve. You'll be able to see in the x-rays which follow the video, all three canals have used easy path EP files. There's still some lag on my end of the video, so I don't know how it's streaming on Facebook. Okay, let's move back to our presentation. Well, that's it from me in talking about glide path management. I hope this was helpful. And I wish you guys try this file at least once. It's surely going to help you achieve those apical anatomies in a much better way. If you have any questions, you can ask me now, or if you want to ask me later, you can connect with me on Facebook or Instagram or mail me directly on my email address. It was great being here on Endo Coffee 3. Please, you guys, stay safe and hope to see you again very, very soon. Before I end, I would like to invite our next speaker, Dr. Michael Jagier from Poland itself. He'll be talking about rubber dam during the pandemic, and it's going to be streamed on the 10th of December. Okay, sorry about the technical glitch. On my end, I couldn't really see the video, but I've been told that it's been streamed properly on Facebook. So now you can ask me questions. I have a couple here already. The first one is, how do we work with the Endostar Easy Path file? After manual file number 10, we should enter the and work with Easy Path 2-3 times without no pushing it forward and repeat this step until we reach working length. How do we manage it in practice? Okay, so basically, we don't have to apply any sort of apical pressure while using these files. These files will glide nicely if you have established the initial glide path using the 10K file. Go in a pecking motion 2-3 times or maybe up to 5 times and withdraw the file. Clean the fruits, irrigate, reintroduce the file, it will reach the working length. I usually work with an integrated apex locator system, so I have good control over my working length. But you can record your working length initially with the 10K file, adjust the stopper on the Easy Path file, and work that way. Second question is, how many times can I use the Endostar Easy Path file? How many canals can I negotiate with this instrument? I was expecting this question. So basically, we need to understand these files are super thin. They are not as strong as your other rotary files, which have a bigger size, bigger taper, and bigger core. So depending how aggressively you've used this file, you can use it in your next case. I would advise you to not use it more than 3 to 4 molars because that's how many times I use it, even though I feel the file can go further for further cases. The best way to decide how many times a file can be used, any file rather, is to always have a magnifying glass in your practice and observe the flutes. If you feel any sort of alteration in the flutes of the file, discard it straight away. Okay, there's one more question here. If the root canal is very curved, the scouting that the apex is always possible only using Endostar Easy Path file, or rather the crown down technique is more recommended. Okay, so if it's extremely curved, what I would do is initially I would establish my glide path using manual files. Then I would take my 2506 till the middle third of the canal. Then I would go back in with my manual files and establish the glide path again. Like I showed you, in and out motion without reciprocating. If you have that, you can go in with the easy path files. If you have any sort of blockage there, you might break the file because there's no glide path established initially. Remember, these files are to expand your initial glide path so that the rotaries move in easily. They are not to create the glide path on their own. Always remember, manual before mechanical. Don't jump to mechanical directly. I hope that answered your question. There's a question by Dr. Mukesh Goel. He's not being able to take the easy path files into the apical hooks, even after 10K and 12K. I feel it's hitting on the dentine. So in this case, I feel you're introducing the file while it's rotating. You need to introduce the file till it slides in, and then start your rotation process. If you have your initial glide path, this file will follow the course very easily. Make sure the initial glide path is established. Check it, verify it, secure it multiple times before you introduce any sort of rotary files. There's yet another question. What parameters must I set to use EasyPart file? What is the recommended speed and torque? This was covered in a slide in the presentation. We need to keep the torque as low as possible. 1 NCM is the recommended torque, and around 300 RPM is the speed you can use for rotation. If you increase the torque, the file might break because of torsional stress. Because remember, this is a very thin file. You can't use it as your normal rotary files. You need to be very gentle with it. The gentler you'll be, the better results you'll get with this file. Okay, I think those were the questions. Also, I would like to apologize. There were a few slides in the presentation which showed multiple studies on mechanical versus manual glide files. I will share it in the comment section so you all can refer to those studies to get a better understanding on how mechanical glide path files enable you to achieve better anatomy and better results in the apical third of the teeth. Well, it was great being here. Please stay safe and I'll see you soon. Thank you so much.